I would like to get next session started by welcoming Dr. Saurab Sharma. He's an HMRC Emerging Leadership Fellow, Chief Clinical Scientist at Pain Management and Research Center at the Royal North Shore Hospital, and conjoint senior lecturer at the University of Sydney. Before this role, he served as a pain researcher, psychotherapist, and educator in Nepal for almost a decade. He has published over 120 peer-reviewed articles and has over 2.5 million in research funding. Dr. Sharma's research is focused around advancing pain assessment, management, and research in low and middle income countries, for which he has received several awards, including Exceptional PhD Thesis Award in 2020, International Association for the Study of Pain John Bonica Postdoctoral Fellowship in 2020 as well, and the Best Research of the Year in 3 separate institutions since 2020. Dr. Sharma founded and currently chairs the Consortium for Low Back Pain in Low and Middle Income Countries, and currently serves as a co-chair for the IASP Global Year of 2025. So, Dr. Sharma, thank you once again for joining us. It's a true pleasure to learn from you and to have you joining us this evening here, morning for you, right?
Thank you so much for the invitation to speak. Thank you for your very kind invitation to speak. Before I start, I'd like to acknowledge the traditional owner of the land where I live and work in Sydney, and the traditional owner of all the lands where you live and work. Before starting my talk, which my bio did not really reflect, which I should have added, was that I started having severe headache as a child. I can't remember when it started, but when I was in 5th or 6th grade, it was very severe, and I couldn't understand what that was, and I would cry because of pain. And I had one CT scan which confirmed that I had no problems at all, and I had to move on with my life. So I had forgotten that before I was invited to this particular conference. So thank you for thinking of me. So let me share my experience of working in Nepal, a lower middle income country, as a physiotherapist, and trying to do some research and navigating the pathway to research. So it's more of a journey and sharing research experience than a proper conference talk. So please bear with me, and I'm happy to receive any questions either after the talk or if there's no time through emails. Before I start, I want to thank and acknowledge my funders, but I would really want to declare that none of my funders have any influence on the way I do or report my research. So the first thing first, my title had equity. So what is equity or health equity? So it's that everyone has a fair and just opportunity to be as healthy as possible, and pain equity is similar in the, so you can replace health with pain. So that is what equity in pain care is. But unfortunately, not everyone around the globe has the very same opportunity to have fair and just opportunity to be healthy or pain-free, or at least lesser pain as much as possible. This is especially true for 85% of the world's population in low and middle income countries. And unfortunately, there are only 5% of the clinical trials that represent this global population. And when people migrate from these countries into high-income countries like Australia or Canada, they're often excluded from clinical trials or research for various reasons: feasibility, and stuff, and they are often considered as difficult population to recruit and also include in study. And one of the big barriers around that is language, but there are other factors as well. Um, and also there are very few trials that really represent or recruit or target Aboriginal people in different cultures or countries. And low value care, or the care that is non-evidence based or that is likely to be ineffective or harmful or are expensive, are also more common in these populations. So there is a big problem, and that reflects inequity in research and care. Uh, we know that we have, in all the slides or talks, we'd have some data on global burden of disease, and we know that the burden is quite disproportionately distributed across countries and continents, and it is skews towards low and middle income countries with disproportionately higher burden. It is mainly due to the change in population growth and also population aging, as you see in the graph. And this burden is expected to increase over the next three decades, and most of these burden will come from low and middle income countries. So there is something that we have to do now to address the problem. The other problem that we have, although we have the global burden of disease data, but very few studies actually come from low and middle income countries, and the data for these countries are mostly modeled or extracted from other sources. So it's not real or true data. What about pediatric pain? So there's a recent systematic review published in 2022 on pediatric chronic pain prevalence in low and middle income countries. So 27 studies are included from 20 different low or middle income countries as per World Bank's definition of countries. There are several types of pain disorders or conditions included. Headache was the most commonly studied condition, followed by musculoskeletal pain and abdominal pain. And the prevalence ranged from 3% to 20%, probably lesser compared to Professor Christine Chambers and team's recent global review on chronic pain in pediatrics or children. I think one of the reasons for that is under recognition of pain as a real problem in children in many of these low and middle income countries. And the other problem is that not many countries, or none of the countries in low and middle income countries, have policy documents around pain or musculoskeletal pain. So we did a series of studies and reviews. The first review was a global review where we try to identify global policies around musculoskeletal health and pain. We find none. So in the next step, we did a targeted search for several low and middle income countries, including a government website in local languages, and also other policy documents and gray literature search. So despite of all that effort, we found no policy documents for musculoskeletal pain or for non-cancer uh, pain. So this is the last column on the screen, but there were other policy documents for other chronic health conditions and nothing around pain. So that's again a big problem. And when we, so compared to the global comparing globally, compared to high income countries, low and middle income countries do have disproportionate burden of pain. And also within a single low and middle income countries, it's a divided world. So it has settings that are resourceful and also settings that are rural and not so resourced. So in rural and not so resourced settings, there's the under recognition of pain and also under treatment of pain. Whereas in more resource setting, mostly in the urban areas, there's the growing concern of overdiagnosis and overtreatment as well. So in many low and middle income countries, including my own country of Nepal and India and many other countries that I know of, there's the growing trend of whole body scans to identify pain or any pathologies in the body in pain-free individuals. So that's overdiagnosis, and any tissue-related problem without pain, if detected, for example, disc prolapse, then they get surgeries and treatment even without pain. So that's a bigger problem and reflects inequity within a country setting. So very briefly about my own experience in Nepal, which is a small country between India and China in South Asia. It has a population of 30 million, and a quarter of the population live below poverty line. It has 123 different languages, so it's very diverse in terms of culture. So I started working in Nepal in Kathmandu University and Dhulikhel Hospital in 2008, and practiced musculoskeletal physiotherapy, and was an educator as well. The constant struggle that I had was to use whatever I learned in my undergraduate training to translate into my clinical practice, which I couldn't because of the different barriers that I'll speak about a little later. And also when people had to come to the hospital for treatment, the access was quite poor because of the geographical constraint and also poor infrastructure. So this is a picture that I took many years back in a rural health camp, where a family member is carrying someone with spinal injury on a backpack or a basket. So we call these as human ambulance in rural Nepal. And we do organize several health camps in rural communities. So we as healthcare professional went to rural community to serve where people couldn't come to us. And also because of the geographical constraints, it is very hard to reach there. And in all the rural camps that we did, musculoskeletal pain used to be the most common presentation in all age groups. In one of the very first camps that I did, I had 500 people to treat in 3 days. So I had to be creative in how I provide care. And to inform my care, there was very little research from the local context. So I couldn't really understand how to use the best available evidence in my own clinical practice. So during my work at Kathmandu University, I reached out internationally through social media to collaborate in pain research, because I did not have national or local mentors because of lack of local research in the area. So I collaborated with Professor Mark Jensen from University of Washington and got a small IASP collaborative grant that helped me start my research program in Nepal. I was very keen and excited, and I wrote the very first few papers that I wrote. But the problem was to publish that paper. So most of the journals that I submitted, I think it has 8 or 9 different rejections, and it was quite heartbreaking. And one of the common reasons that I got for desk rejection was that your paper does not fit for our international journal, so maybe submit it to a local journal. And the editors did agree that the paper was of high quality. That was a problem, but later on, after many rejections, we were able to publish, and it did get international media attention, and it was featured in New York Times magazine, so which I was very excited about. There are also comments from reviewers and other colleagues that we do have evidence from high-income countries, so why do research locally or waste time or resources or something along those lines. The problem is that high-income countries and low-income countries are quite different in terms of various factors, and also they do have different research priorities, and they are on different time point in the research landscape. For example, in high-income countries, there's growing research in highly tech research areas, whereas in low and middle-income countries, they are struggling with basic life needs, and also research or care around essential trauma management. So It's different healthcare system and settings with also different disease burden and healthcare needs. And also there are different social demographics and socioeconomic positioning, including language, culture. So findings from one language or culture may not really apply to another language and culture, and also health systems. So we do need research locally, and that has to be um, identified and acknowledged, and also research that's considered unimportant from high income perspective could be groundbreaking research for the local context. So wearing that hat as editor and researcher is needed uh, while evaluating research from low and middle countries. So what areas that I faced, or many people or researcher face while conducting pain research, and also this applies to any areas of health research, especially in the non-communicable disease area. One of the key barriers is that pain isn't recognized as a priority for research, because there are other competing priorities like communicable disease, trauma, and other non-communicable disease that people die from. And in Nepal, especially when I got started in the National Health Research Agenda, published in 2015, before my PhD, pain was only mentioned once in the National Health Research Agenda. That was only to describe randomized control trials. So research from low and middle income countries are needed to inform local care. So there are issues with generalizability of research findings from high income countries to low and middle income countries. And there are several barriers to pain research in low and middle income countries. The first one is priority itself. So pain isn't considered a priority area of research. For example, in Nepal, in 2015, pain was mentioned only once in the National Health Research Agenda to describe randomized controlled trials as painful process. So pain wasn't listed as a priority condition at all in 2015. There is lack of research funding. There is lack of a research workforce that ties with the previous two, and um, there aren't many PhD scholarships or postdoctoral position to or research specific position to lead research, and also education around research isn't very embedded within undergraduate and postgraduate training. And also language is a big barrier in order to do research. For example, having reliable and valid instruments while conducting research, and also while publishing. So writing manuscript in English for many people in second language is hard. So there are several barriers to conducting pain research. So to overcome some of these, I embarked on a PhD, and one of the goals was to set up a pain research agenda in my country of Nepal. So we did a scoping review to understand the research landscape, identified research gaps, and then prioritize research area based on most important to least important. We sought collaboration and funding. I was successful in getting some fundings, but some of or all of these fundings were either collaborative grant to support research visits, or only supported my salary. So there wasn't any project specific funding. So very briefly, the findings of scoping review informed the research that I did in the next many years. The three different priorities of lack of treatment-related research, especially in rehabilitation area. There was only a couple studies on outcome measurement or assessment of pain. And also, although there were a few studies on epidemiological aspects of pain, but these were small studies conducted in specific populations, like dentists or doctors assessing or evaluating burden of or prevalence of neck pain or back pain, very small studies and poor quality studies. We recently updated this scoping review, and quite we had quite productive pain research in the past 5 years or so. And in both of these reviews, pain in children were very few. So papers in the 2019 review and 9 papers since then. So based on the 2019 review, which drove my research agenda, the first priority area for my research was around improving pain assessment of pain and other psychosocial factors in people with pain. Treatment around pain was the second priority, and also pain epidemiology. One big problem clinically and also in research was that when we used the most recommended tool for pain assessment, that is the numerical rating scale, in adults, people who didn't understand it, so they would be very uncomfortable to complete the scale, and then they would ask me to complete the number or the scale on their behalf. So clearly it did not work. So we tested empirically which of the 4 commonly used scales are most preferred by people with musculoskeletal pain in Nepal, and which of these scales are associated with the most error. So the visual analog scale and numerical rating scale, the most commonly used scales, were least preferred in Nepal, and also they are associated with the most error. And the faces rating scale was a clear winner, followed by verbal rating scale in terms of preference as well as least number of errors. We replicated this study in 2 different countries, Bhutan and India, and findings were quite similar. So in Bhutan, also like Nepal, faces rating scale developed by IASP was the most preferred scale, and verbal rating scale and faces rating scale also had fewer errors. So meaning that for non-Western cultures, um, either verbal rating scales or faces rating scales could be the preferred scale to use. And also this could be a consideration for research in pediatrics and people who are older adults, and also for cross-cultural or cross-country studies. So with that information in mind, we then translated and validated several scales that are part of core outcome set recommended scales for chronic pain, for osteoarthritis and back pain. So these are some of the domains that that's some of the translations that we did reflected. So we translated host of different scales. One key consideration in our mind was to use or translate scales with verbal rating responses, which was the second most preferred and also were associated with least error. The reason why we did not choose the faces scale was that the verbal rating scale offers advantage to use over telephone, and that was one of the key strategy to recruit in local research, and also to follow up on research because of the geographical complexity in Nepal. The second problem that we had, can I check how many minutes I have, because I did lose significant time and my timer is off.
We have 20 more minutes.
20 more minutes. Okay, perfect.
Yeah.
Thank you so much. So the second problem in clinical care was understanding really what patient meant when they described their pain and symptoms and how they felt. So we did a qualitative study in Nepal and asked more than 100 people with chronic pain to describe their pain in their own words. And then we compared the responses with 2 different samples from the United States. And there was some similarities, but also major differences in the way people described pain across cultures. So in Nepal, people tended to describe their pain in terms of sensory state words, so using words like cut, cut, chum, chum, but which aren't actual words, but these did tried try to explain or describe sensory state of words. So these you can think of these words as TikTok that describes sound of clock. So they would use similar words to describe their pain. So this was quite unique to Nepal, and I know that is similar in India because I was trained in India and in other countries as well. So how people describe pain is quite different, and this is quite important to many people internationally to be heard and believed, and that the clinician understand their pain. So there's one example that a person with uh, osteoarthritis of knee or knee pain felt cut pain in their knee joint, but their clinician or doctor in the UK could not understand, so they had to fly back to Nepal to really tell the clinician what they were feeling. So these could be really important for patient that they are understood. I'll probably skip this slide. So this was around cultural differences internationally and between countries. And there are also differences in terms of religiosity and spirituality. But very quickly, what I want to highlight here is a qualitative study that we did in Nepal with people with chronic back pain. So this is a study in adult. So we categorized or created themes around four different domains, and one was sociocultural. So historically, pain used to be considered normal in rural settings, but now because of globalization and also modernization in medicine and access to um, diagnostic tools, there's more shared beliefs as Western cultures in terms of their pain. So a lot of pain is influenced by healthcare providers' advice. But things that are unique are also around a social aspect of pain, that pain, not just back pain, but any kind of pain is not just a problem of one individual, but also is the problem of the family, or some in rural settings is the problem of the entire community, because people live in a communal setting. So if one person is affected, the entire family or the community is affected. And also there are superstitious beliefs about pain and its causes. So many people think that pain is a punishment for their past sins, or sins in their past life, which can be significant um, contributor to their pain and injustice around pain. The second priority area that we worked on was around improving pain treatment. So we picked up an intervention that applies through all pain conditions and also are recommended as first line care, which is education. And as research around pain education is derived again from Western countries, and much of it could not be translated or used directly in our setting. So what I did was I developed a pain educational resource and a program, basing it on solid foundation of curriculum, and using local patient stories and metaphors. And we replicated that study in India also. So we have resources for pain education in four different languages, in languages that are spoken by 800 million people globally. And as you see at the top, none of these research were funded, but was collaboration with students and colleagues locally. In regards to Nepali pain educational program, so during my PhD, I developed an educational booklet. The problem with that was many people can't read, and even if they can read, it's not their preferred way of gaining knowledge. So I conducted a co-design study here in Australia with Nepalese speaking groups through a small seeding funding to co-design pain educational treatment. So what care to deliver or receive for back pain or any chronic pain, and how to deliver that care. So we are currently developing resources, digital resources, and videos around that. And I recently got an investigator grant to do similar work in 5 different culturally diverse communities and languages. And these culturally diverse communities who live in Australia are originally from low and middle income countries, and these languages are spoken by 2.2 billion people globally. So I'm hoping that once we have the output, we'll have global implication and reach. So to target the third priority around the need of high quality epidemiological study, so we conducted a pilot study in a rural village through a door-to-door survey. So as you know, geography of Nepal is quite complicated. So we had to go and knock each door and gather a lot of step counts. And also when they were not available at that point of time, we'd have to go back again, so more step count. So it wasn't a easy study to do, but a fun study. So with this, what we found was that chronic pain, even in rural settings, is very common. 1 in 2 people experience and report chronic pain. Um, so it's a big problem, but we did not really assess the impact of chronic pain in individuals in that study. In 2019, we were able to embed one question on population-based national health survey in Nepal, which was conducted across Nepal in all the 7 provinces, again through the same door-to-door method. And we found that activity or work limiting low back pain was experienced and reported by 1 in 4 individuals. So it's a big problem in Nepal. We are still working on chronic pain prevalence and burden through collaboration with the University of Dundee. And we are hoping to further partner with Ministry of Health and Population to embed more questions around chronic pain and potentially also study children and children with chronic pain. And we have recently submitted an IASP collaborative grant to study chronic pain prevalence in children. So please keep your fingers crossed for us. So during my research journey from 2014 around to 2019 and 2020 was when I submitted my PhD. So we are able to include musculoskeletal pain, at least low back pain and osteoarthritis and other musculoskeletal problems within the National Health Research Priority Agenda that was revised in late 2019. So which we thought was a great achievement, and we are advocating for more research funding for pain-related problems. So that was a story about Nepal. But again, there are so many low and middle-income countries who have the same barriers and challenges that I faced in Nepal. So to help colleagues in other countries where they lack local mentorship and resources and time to conduct research, I set up a consortium of researchers, clinicians, and patients from 35 different low and middle income countries with hope to understand pain treatment practices and burden in these countries to develop pain research priorities. The project is currently running and co-design effective and culturally appropriate pain treatments for these countries. So it's a work under progress. The first study that we did was a mixed method study by including respondents and partners from 32 different countries, and all the orange marks on the heat map are countries included. The black marked countries are high income countries, so those are excluded from the study, and the white or no marking are the countries we could not include. And these regions in the majority of Africa tend to also be the countries which we struggle to find participants or contributor for other studies as well. So what were the top treatments that are currently used in low and middle income countries? So pharmacotherapy is the most commonly used treatment, followed by electrotherapy, and both of these aren't the first line recommended treatment. On the other hand, the first line recommended treatment, education and self-management, were not used as much. It was used as much as traditional healing approaches, which also included bloodletting, that is cutting part of the body to let the ill blood out of your system, so which can be dangerous as well. So being mindful of the time, I'll quickly run through the qualitative study findings. You can read the quote yourself. So by large, self-management was an universal method to managing pain, and social connections played a very important role. So many people first seek advice from their family and friends for their pain treatment, and traditional therapies play important role. Medications were quite commonly used, and imaging in particular is common in so many countries, and in many lower and middle income countries, people can directly go to a radiologist and can prescribe imaging for themselves. So I see that as a problem. And also there's a lot of reliance on passive treatments um, around the care pathway questions. So social determinants influenced people's care pathway, and also health systems are not prepared quite well. So in some countries, there aren't allied health professionals or pain trained professionals in their country, so they have to travel internationally to receive treatment for their care. Before I end, I'd like to highlight two different projects, global projects, that I think is relevant for this conference. So the first one is the one led by our amazing Dr. Emma Karen from University of South Australia, to improve the way we collect and report equity relevant data internationally. So this was a global multi-staged project, which started with scoping reviews globally, Delphi, and we did not have enough participation from people from low and middle income countries and from minority groups, or what we call as hard to reach participants. We conducted targeted recruitment from these contexts. We then had a consensus international process followed by a series of focus groups. So it was quite an extensive project, which I was fortunate to be part of. There are several outputs listed on the screen. I'd like to highlight the key findings. As I said earlier, the overall intent of the program of research was to identify what are the key equity relevant data that we need to collect in all human pain research. So we had two sets based on the global consensus. Set A, which we think is the mandatory items to collect. So these are on the screen. So I'll quickly run through that. So the questions around age. So what is your age? Very simple. Questions around race, ethnicity, or culture, which was the hardest to get consensus on because of different practices globally, and also international norms around collecting data. And in some countries, especially in the European region, you can't ask questions around race and ethnicity as a legal obligation. So that was the hardest one to come on consensus, but we did agree that it was an important question to ask, and we'll have to tailor locally for the local need. And highest level of education, how are you able to afford your living expense, which was considered important. Current paid situation at work, where do you live, or living situation, gender identity, and sex were the set A. So there's also set B, which I highly recommend to look up this particular paper to see what sorts of questions are important, and you could adapt based on your own local context and research. And this particular website has other several resources, for example, a REDCap survey, which you could directly download into your REDCap system and then make minor edits as you see fit for your own research. The other one was an international project led by Professor Andrew Briggs around understanding health system strengthening and what should we do to improve health system strengthening for musculoskeletal pain and health internationally. So in this body of work, we recruited participants from 72 different countries, and LMIC was quite well represented in that. And also we had different interest holder groups contributing, including people with lived experience and people at policy level. Global coverage was quite high, and the map in the African region is similar to what you saw earlier. And also that we had representatives from 116 unique global organizations. And we had several recommendations for health system strengthening for musculoskeletal pain through that program of work, and we aligned that with WHO's pillar for health system strengthening. There are several specific recommendations for global use, as well as some targeted recommendations from LMIC, or low and middle income countries, which you can see in green boxes. One that really stands out for me is around capacity building in community-based care for musculoskeletal healthcare, which I think will apply to other pain problems as well. So before concluding my slide or talk, I would like to highlight this global initiative and ISP's focus on pain management research and education in low and middle income countries as the feature for Global Year 2025, which I was fortunate enough to co-chair with Dr. Margarita Calvo from Chile. So we had 35 members from 26 different countries who contributed to the to the Global Year, and we produced 16 different fact sheets and a translation in 18 different languages. So I would really encourage you to visit these fact sheets, and if your language is not listed on the screen, and if you want to facilitate translation in your own language, please do feel free to reach out. So I'd like to end by some key messages. I know this is very broad, but I'd like you to reflect on how you may be able to contribute to pain care and equitable pain care for people from vulnerable groups across the globe, particularly those who are disadvantaged socioeconomically, those living in low and middle income countries. So to summarize, LMICs, or low or middle income countries, have different research priorities to high income countries, and they face many more challenges than high income countries. With my lived experience in high income countries, doing research in high income countries isn't easy either, but low and middle income countries face disproportionately higher challenges. We do need a true global health approach to co-design treatment and treatment care pathways for addressing pain in vulnerable populations. And everyone has a role to play, and I encourage you to reflect on how you may be able to contribute to this, either as a collaborator or editor of a journal, or a reviewer or funder. So I'd like to thank all my funders and amazing collaborators internationally, and I'm happy to take any questions. Thank you. Thank you so much.
Thank you, Dr. Sharma. That was such an inspiring presentation, and I am grateful you were not deterred by the many challenges and barriers you faced over the years, and you overcome most of them, and you're here telling us about this incredible journey. I will open the chat for questions from the audience, but I have a question already from Jennifer Stinson. Jen, do you want to talk?
Hi, Saurab.
Yeah.
Great.
Hi, Jen.
You talked about your last statement or last point was about getting everyone involved in this. And so I wonder if you could just talk to what's the role of patient engagement and research in low and middle income countries. It's very important in high income countries. We use it a lot to sort of show what the priorities are from patients and families, and it helps to, using a patient voice helps to make people more aware and advocate. So In none of the speakers' talks, really, I've heard a couple of people mention patient engagement, but I wonder if you could talk to it a little bit from your perspective.
Yeah, that's a great question, Jen. And when I started with the research, I did not know that patient could actively participate in research, and I was quite naive, and I'm still learning. So there, and also many low and middle income countries is a hierarchical system. So researchers or healthcare providers are on the top and patients are below. So there's the hierarchy. So it's not a common system in many countries to co-design research or involve research patients in research um, directly as co-design. Although my research are informed by my patients, but that was my reflection through what I heard from them over the years. So I see that as a big barrier and challenge as through CAPA, you and I know that we struggle to find partners from low and middle income countries to people with lived experience from low and middle income countries to contribute to CAPA and other initiatives as well. And I see that as a major priority. And we are working on a grant application around that to facilitate involvement of people with lived experience in pain research in low and middle income countries, and developing a framework and to help assist and then advocate and all of that. So yeah, I think there will be a movement through CAPA and from all of us individually in that space. But unfortunately, currently there isn't much based on what I read, see, and interact with colleagues internationally.
Thank you.
I think just for the audience, Jen included a link in here for the Global Alliance of Partners for Pain Advocacy. So if you want to hear more and learn more, just click on the link and you will get some more information. Well, I think just because of, yeah, please go ahead, Dr. Sharma.
No, sorry, so if a thought came in my mind, so very quickly. So we did struggle to recruit people with lived experience in all of our research. So that is the rationale for the project that I'm currently planning, or the grant application that I'm planning. So I wanted to highlight if there are any people with lived experience in the conference this afternoon, especially from low and middle income countries region, please feel free out to have a chat, and then if you're willing to contribute, you're most welcome.
Great, amazing. So I think just on interest of time, I will end this session here. I'd like to once again thank you for this brilliant presentation, and I'm looking forward to see what you're continue to work on and publish next, and how we are advancing pain care globally. Thank you very much.
Okay. Thank you so much. Yeah, thank you so much.
Thank you.